I come from a place, the daughter of somebody in a long-term care facility. I've worked as a care aide and as a social worker in long-term care facilities and as a mental health consultant in long-term care facilities in both BC and in Manitoba. As well, I've got a background of doing a lot of different kinds of research in mental health, social isolation, and caregiving. All that said, I'm coming at this from a few different places, but today from the Action for Reform of Residential Care, which is a BC association, voluntary. So the objectives for today are to describe what a reformed long-term care system would look like, the strategies that the province has undertaken, talk a little bit about that, and how ARRC, and which is the acronym for Action for Reform of Residential Care, how we're trying to move things forward, and also, and the biggest part of this presentation or the discussion, I hope, is what can we all do together to move things forward, because it is a big job. So Action for Reform of Residential Care is a voluntary association that was born out of the horrific things that we read about in the media when COVID first appeared, and there were all the deaths in long-term care and the neglect and abuse that was revealed, and the public was, activated, really became visible to the public what went on in long-term care. As you've heard in many of the different presentations, we all know that what led to such devastation in long-term care was really a lot of the systemic issues, like the precarious workforce, that long-standing issues that many of us in the field knew about, but there's been very little change or addressing them over the past number of years in a comprehensive way by governments. So our aim in ARRC was to come together and to build public will to actually make change, trying to ride on the wave of public concern from the media, which did a great job of bringing everything to the forefront. We wanted to make people aware that these issues were long-standing. We also want to advocate for vulnerable people living in long-term care. This is a very vulnerable population in every sense of the word, as are their families, and they are voiceless and hidden for the most part. And finally, we wanted to support government in taking action to reform long-term care in BC. We've gone beyond BC, but actually we are trying to focus our efforts here now, just here. So the care in crisis. I think we all know about the care in crisis. And again, this has been a very long-standing thing and people have talked about it. The pandemic just revealed these deficits in care and exacerbated them and exaggerated them. And it made it very clear that long-term care is not a place where most people would like to end up. And in fact, there's been surveys since that show that most people in fact fear going into long-term care. There's a consensus across not just BC, but all around the world really, that the pandemic only exacerbated issues. They didn't cause all the issues. That I think we know, actually, we all know what these issues are, I do believe, and we actually have a lot of evidence to move forward, much of which we heard about here. But why don't we move forward? We don't seem to be able to move forward, in part because things are piecemeal, I would argue. We need to action, and the action is in fact urgent. The conditions are actually not as good as they were before the pandemic, and there's a danger that as things settle out, that what has become the norm today will remain the norm. And what I'm talking about is that COVID with its deaths, with the precarious workforce, the effect on people in long-term care, people working in long-term care, the inconsistency between facilities about visitation and regulations that had such a profound impact on families. And now the attrition that's related to COVID and the loss of staff, few people applying and not looking like a very wonderful career opportunity at the moment, because of the stigma attached to long-term care, even more so now. So I think it is worse. I think, we all know about the institutionalized care routines, the culture and the staffing levels that don't allow for person-centered or relational care, about how frontline staffing practices undermine quality of care. I'm thinking about the short staffing in some facilities that is not, you know, a one-off or a now and again, but a chronic sort of thing. The overuse of casuals for various reasons, that the frontline staff don't have the support that they require, either the education, the knowledge, the skills, or the specialized support for the very complex residents that they're looking after, those who are palliative, those with mental health issues, those with responsive behaviors, pain management, all those kinds of issues. There's not been a great deal of education mandated for people working in long-term care. Consultants and teams in nursing, social work, rehab, mental health, the number of those people, allied professionals, has been eroded. Families have no voice, and this was really made very clear through the whole COVID lockdowns and the desperation of families to get in to see their loved ones with very, very little voice, little impact in different facilities or with the public health people. They felt very disempowered, much more disempowered even than before. And care resources, of course, we all know, haven't kept up with the increasing care needs and the inadequate physical environments, which have, again, hark back to what Carol Esterbrook talked about, the hospital model, the institutional model with its hierarchy and with its practices, and with the way the whole units are laid out, is a problem in itself. Habib Chadre talked about that in his physical environments and how they can support residents' well-being. So we know what needs to be done. So in terms of paradigm shift, what we argue for, and we're not the first, lots of people are arguing for a paradigm shift. And we've been talking about, we've been talking about this for years and years. We've been talking about the need to move from an institutional model to a relational model, that to a more humane, person-centered care, person-centered model, and I would say family-centered model too, for such a long time. I've been in this field since the 80s, and we talked about it then. You know, we're still talking about it, and we go on again, off again, because we know it's right. And all the people who work in long-term care, who work in facilities, they know that this would make much more sense than the way things are done. But the way care is organized, the hierarchy sometimes subverts this, the culture, the lack of resources, and so on. What we do need is an adequate number of staff, the right mix of staff, well-supported staff who are able to facilitate resident quality of life and human rights. We also need that paradigm shift that moves it from that institutional model where the physical care is everything and the social, emotional, and mental health care takes the back seat, is not considered essential. That was really actually kind of underlined when families were kept out, because unless they were essential care, meaning essential to the physical care of a person, they weren't allowed in. Emotional care wasn't really considered. So we want to see, with this paradigm shift, long-term care facilities where people thrive, where it's a place to enjoy life, not to just survive. We want to see education through leaders, staffs, residents, families, and the public. We want to see an adjustment for staffing numbers, the mix, and the organization's focus of care and work to implement a model that provides safe, respectful, individualized relational care. We want quality of life to be the focus. You can have quality of care without quality of life, but you do need quality of care for quality of life. But they're different. We need to be able to implement it. We also need ways to actually monitor it, measure it, and report on it. We need engagement with and support for families. We need mandated support for family councils, because they can be advocates and partners in care. We need to have transparency and accountability for high quality care and the use of public funds for care only, not for profit. And finally, we want effective monitoring and enforcement of care standards. You know, most people would agree with all this. There's very little to disagree with. You know, who wouldn't want to see care before profit? Who wouldn't want to see family councils that are actually supported and able to advocate? They have the most connection to the residents. They care the most. What about quality of life? We all talk about it, but what about being able to actually make that the primary focus? So a reformed long-term care system would have culture, and culture is important, and leadership that facilitates quality of life. And leaders need support too. They also need education. There'd be an emphasis on social, emotional, and relational care. The workforce would be well educated and supported, and have working conditions that actually enable them to live, as somebody, I think as Carol Estabrook pointed out, very important. Appropriate number and mix of staff, and these standards that I mentioned that are monitored and enforced, but actually focus on quality of life. A less institutional physical environment. All those kinds of things are important, as is the increased accountability for care that Isabel McKenzie talked a little bit about. There's lots of people working on trying to improve long-term care besides ourselves, and I'll just mention a few of them. For example, there's the Restoring Trust document. That was certainly one that we referred to in our work, and very significant in terms of how the workforce needs to be supported. The guidelines that David Kahn mentioned, the guidelines for mental health services and long-term care, that the Mental Health Canadian Coalition for Seniors Mental Health and the Mental Health Commission of Canada share are actually very excellent, and there are some for long-term care. There's also most recently the Canadian Standards Association contracted with the Canadian Coalition for Seniors Mental Health to create supporting mental health and well-being in residential care that may contribute to a new national guideline. The national standards that have just been developed we have the hope that they're going to make a difference, that if they're implemented, monitored, and so forth, that they can have a positive impact on people's lives in long-term care. Things that, they're not internationally, there's the United Nations and their anti-ageism work that they're doing, and federally, the healthy aging that someone I think spoke about, and age-friendly cities, all this contributes to what could help us to make this shift in how we think about long-term care, how long-term care is included or not included in our communities, and how the community is included in the facilities, and so forth. It would be a system where family councils have a real voice. And I think the note that Andrew Picard made about, or maybe it was Isabel made about Andrew Picard's talk, that because he's not been molded by the healthcare system, he can see it a little bit differently. I think that's really very true, that it's very hard from the inside when we work in these facilities to really imagine how they could actually change dramatically, how they could actually be reformed. People coming in from the outside, they see things differently. They haven't been socialized into the system the way we have. I always remember when I used to train people, nurses' aides, when they first started in Manitoba, one of the things was noticing how in a short while, they started off keen, they started off understanding the principles that we were trying to import to them, but over time they became acculturated to whatever unit they happened to be on, and the norms were different. So ARRC, the Action for Reform of Residential Care, I'm going to talk a little bit about what we've been doing. Now, we started off in, as I said, when COVID first started, a small group of people, but we have gathered a membership. And our focus was really trying to, first, to educate people. We wanted to teach people, tell the public about what the issues were, get them fired up, make them aware. I guess that was somewhat successful, but COVID intervened right away. And then there was an election. So it took us a while actually to really get up and running. And then when we got up and running, we were kind of shut down from that respect because of COVID. The government has done some things here in BC to help with long-term care. One of the things is the funding for 3.36 hours of direct care. That was always on the books, but some facilities actually weren't getting the money. Of course, that is under what the desirable research-based level of care is. Wage leveling, which is $25 an hour across the sector, should help with the precariousness of the work for people in the field, and we think that will stay. The one site rule that was initially implemented, it's changed now to more like clusters. I'm not actually sure if with all the changes in the public health, whether it changed completely, but it enabled, what it did was there were a lot of people working in a lot of different places, and what it forced was people to sort of choose one employer, and of course they chose the best, and then to only work in that one site initially, and then later into kind of a partner site. So people who hadn't been able to get the hours were now getting the hours. They're training 7,000 healthcare aides. They're increasing the seats for training nurses, and certainly we need many more RNs, LPNs too. And part of that is about having the seats, if you like, at the universities to actually train them. Increased support for infection control for sure, and the CSA has a standard out now that we've spoken about today. Restricted family and friend access to long-term care facilities. That was one of the first public health orders. It had a devastating effect, of course, on families and also on residents. And there's research coming out now about the mental health impacts on both parties. I think, as well, as I said earlier, it really made people feel very, very disempowered, very angry. Of course, on reflection, maybe they wouldn't have done it quite that way, but it was a learning process for everybody. But it did have, it certainly did have repercussions. Certainly social isolation. When you think about social isolation, the whole lockdown idea and sometimes the reduced staffing made for some definite negative impacts on people. The commitment to 1,500 new public beds and developing a more transparent, accountable funding model is something that's been ongoing that will enable them to be able to see where the money for care is actually going. One other thing that we were told about was the contracting out. As contracts come up, they're looking at what would you call it? Bringing a dietary and laundry people back into the public system after having been contracted out for quite some time, which would make them part of the team again. So for ARRC, what we've done, one of the things we did was create a, well, I guess we did a number of things. One of the things we first did was create national petitions that were quite successful. That is to say, they were read in the House of Commons. And we made two of them, and they were about national standards. We were asking for national standards. We wanted the workforce issues addressed. We were talking about ending contracting out and limiting profit making. We had the first one, huge number of people that signed on. Second one, not quite so much. And I think that reflects that the changing interest of the public, you know, in the last year and a half, from the very beginning when they were horrified and wanting to act, to now where it's sort of more on the back burner. The other thing is that we did a letter writing campaign to MLAs to support reform of long-term care. We don't really know what impact that had. We're not experts in advocacy, but something we're certainly trying hard with. The other thing is the ARRC report. I guess the ARRC report is something that we put out in December 2020. We were slow in doing that, in part because there was an election coming up, and that election was in October, and we were a little bit slow to get there. But when we did get it, we were told that it was very useful to the provincial government. We presented it to Adrian Dix. That is to say, we sent it to Adrian Dix, and we sent it to Mabel Elmore, who's the Parliamentary Secretary for Seniors and Long-Term Care. That was led to discussions. We've had ongoing meetings with the Parliamentary Secretary since then, about every 3 months. The report itself is on the website, and there is also in the program Chronicles. The Conference Chronicles as well has a link to it. It's an evidence-formed analysis of issues and practical recommendations for improving the quality of life in long-term care. We also have a section on issues specific to, you know, various topics. For instance, we have one called Considering a Moral Compass for Long-Term Care that was written by some of the presenters here. We've got another section called Giving a Voice to LGBTQ2S and Seniors in Long-Term Care. Our report was quite comprehensive. It covered things like licensing, what makes life worth living, standards, the roles of families. It talked about staffing levels, workforce issues, training, and I guess also about the person-centered care model. It talked about all those things, but these, in the appendices, people went into depth on things that were important to them that they feel needed more spelling out. So another thing we had was the call for mandated social work positions. Another one was ensuring psychosocial health and human rights in long-term care, physiotherapy, and also the role of geriatricians. So various people have added to our report, and it is a living document, and we bring all up the new ones every time we come in and speak to Mabel Elmore. What we would like to do now, moving forward, is to increase public awareness about issues. And now that the public health regulations allow for it, maybe we'll be doing more public sort of awareness education pieces. We want to build our voice. We have a membership of about 800 individuals. We also want to leverage our supporting organizations. And the supporting organizations there's about 60 of them, and they're very diverse. They include unions, they include seniors organizations, professional associations, all kinds of stakeholders that are engaged or in one way or another in the long-term care system. These organizations signed on to our document. So when we first sent it to Adrian Dixon, to Mabel Elmore, we had on there the 50 organizations at that time that had in fact supported the recommendations, and yet I'm afraid it still didn't give us much leverage. What we're looking at now is how can we use the supporting organizations to leverage change. And just the other day, it suddenly occurred to us, which tells you how relatively naive we are about this, how many people, how many members do all these organizations have? Like, what would our voice really be? And we haven't got all the information yet, but we're at the number 300,000 already, with only about half of the organizations counted as yet. What would it mean if we could send out an email to every one of those people asking them to do something on the same day, for example? So we're thinking about how can we leverage the membership and the supporting organizations, because as with a lot of organization, ARRC, the actual working ARRC, is likely only about 5 people. So most recently, what we've asked our provincial government to do, and this was part of the original ARRC report, but we're really focusing in on it now. We want them to articulate a vision for a comprehensive reformed long-term care system and create an action plan to implement the vision. Because one of the things we've heard here, there's so many great things out there. There's pockets of excellence where they are doing person-centered care. Habib Chaudhry had his poet, his person-centered environmental assessment tool. Carol talked about pieces. There's so many parts out there to the puzzle, but they're not put together in any comprehensive way. So we have a lot of different little things we're doing here and there that can have a significant effect on a small group of people, but we don't have a comprehensive approach. We'd like an independent chair on this. We'd like to have this provincial action planning meeting, actually an action planning, and we want multi-stakeholder engagement. We would like to start with the people that have signed on to ARRC. We would like the government to start with the people, but only the government can have this action plan, or we're calling it advisory forum now. Only the government can actually appoint and create this, because only the government has the money to make the changes that we want and the power to make the changes, right? But we would like to see a multi-stakeholder engagement. At the time that people are invited, we want it to be building on the widely supported ARRC recommendations, recognizing that there could be many others. We want all voices to be heard and part of the decision making. So we're talking about families, residents, as well as people who work in facilities. We would like to see provincial funding and rollout. Again, there's so many good things that would be done piecemeal, but we can't be piecemeal anymore. And the one other point I'd make about this is we believe that the long-term care system strategy needs to be considered and developed. This action plan needs to be developed in the context of all senior services, including home care, but not to be diverted by home care at the moment, which certainly has its issues, but let's focus on making this piece of the system better, supporting more quality of life and well-being, and come back to home care, but recognize where it fits in the system. So the question I want you to think about is, how can we work together towards getting this multi-stakeholder task force up and running so that we can create an action plan, a provincial action plan that focuses on improving quality of life? So think on that. But in the meantime, change is slow. And as individuals, we need to sustain hopefulness, stay informed, take breaks to sustain physical health, and so on. Like, I was asked to be hopeful. I am somewhat hopeful, but it's also really hard to keep pushing. As many of you know, keep trying to get, different avenues for how can we get these changes that we want, and to be constantly stymied, because ultimately it is government that needs to make the change. So we do have roles, though. There is that whole idea that in wherever you are in the system or in your lives, you have influence, and part of it is using that influence in whatever sphere we have. So I was just brainstorming with myself, policymakers can engage stakeholders like family, facility, and policy development, for instance, in relation to having independent family councils supported. Facility operators can develop their mission statements, policies, and practice that facilitate relational person-centered care. They can implement national standards. The leaders in the facilities can ensure continuity of care through their staffing patterns, making sure there's way for staff to share information and to feel valued, and that they can actually use the knowledge they have to support people. And finally, families and friends, and some of you are families, some of you are friends of somebody in the long-term care facilities, we should be starting or joining family councils. That's an uphill battle. And as citizens, we'd like you to join ARRC. We'd like you to join an MLA writing campaign. We would like you to go to our website, which is arrcbc.ca. Join up, contact me if you're interested in being more engaged. And we want your ideas. How can we push this forward? What is the way, if you're in a position of policy, practice, or advocacy, what are the ways that we can move the agenda forward? How can we get action in this province to actually reform long-term care and not just keep doing piecemeal things that won't add up to a reform? It's just like moving the chairs on the Titanic. So again, how can we work towards a multi-stakeholder task force to create a provincial plan? If anybody's got any ideas, I'd truly like to know them.